So, good afternoon, everyone. My many great thanks to my mentor, Bada sir, for giving me this opportunity. And my talk will be on ICG in esophageal surgeries. So, I'll be talking on the principle of ICG, followed by its role in esophageal surgery and the evidence that is available. The principle, Indocyanine Green is the only approved dye for fluorescent imaging for near-infrared spectroscopy. If we see the properties, it's a tricarbocyanine dye, binds exclusive to the plasma proteins, remains in vascular spaces with minimal tissue binding. It emits a fluorescent signal when exposed to infrared wavelength with excitation wavelength of 750 to 800 nanometers with emission wavelength of 830 nanometers, excreted rapidly by hepatocytes in the bile and eliminated via feces without reabsorption. It has a half-life of 4 minutes, but it can be repeated every 15 minutes while in an intraoperative setting. And this looks like a complex physics, but it's very simple. Your optics in the operating room should have only two extra filters. From light source, you have a high pass filter that eliminates fluorescent wavelengths, and light goes to the ICG and it stimulates the ICG bound proteins. Then the emission wavelength again filtered by the low pass filter, and it is sensed by the sensor. So clinically excellent properties for ICG. It's non-toxic, non-ionizing, ideal for angiography because it remains in the blood space, and a very short lifetime and allows repeated applications, that is every 15 minutes. And it has a very high signal to noise ratio, that is no noise from the surrounding tissue because no autofluorescence in the tissue. And it is simple and cheap. As I told you, it requires only two extra filters. And coming to its application in esophageal surgeries, it's mainly three roles are there: to decrease the anastomotic leak, and visualization of thoracic duct, and identification of draining lymph nodes to assist in lymphadenectomy. So the first one, to decrease the anastomotic leak, we know it is a serious complication with the incidence of up to 40%. It is associated with morbidity, mortality, and impaired quality of life. So one of the most common reason is deficient perfusion of the gastric conduit. This is the most important risk factor for anastomotic leak. So how we will assess the vascularity of the conduit? Historically, we used visual and manual inspection by color, bleeding, and right gastroepiploic artery pulse. Those methods were very subjective and low predictive value for AL, and it underestimates hypoperfusion. And later we came across for Doppler ultrasound, laser Doppler fluorometry for more objectivity, but they are less reproducible in operative setting. So why ICG and near-infrared imaging? It's easily reproducible, it's less expensive, and it has good correlation with anastomotic leak. So coming to the technique, we give 2 ml of ICG solution. The concentration is 2.5 mg per 2 ml. It is injected IV followed by a 20 ml saline flush. And gastric conduit is assessed for perfusion after 1 minute by activating ICG mode in your laparoscopic system and Firefly in robotic platforms. And the perfusion can be assessed at 3 points, that is before conduit preparation, after preparation of the conduit, and after the anastomosis. So this is how it looks like in an open surgery or laparoscopic surgery in the image above. And this is robotic Firefly system showing ICG fluorescence in intrathoracic anastomosis. So coming to the evidence part, we have a systematic review and meta-analysis for Indocyanine Green imaging for prevention of anastomotic leak in Ivor-Lewis esophagectomy. Note this point, this is only for intrathoracic anastomosis. They have included 32 studies from 2000 to 2020, included more than 3,000 patients, 12% ICG used. Dose used ranged between 5 to 21 milligrams. And results, anastomotic leak rate was similar between both the groups. There is no difference in mortality and length of the stay. And they have commented that perfusion assessment with ICG is more relevant in cervical anastomosis, not in thoracic anastomosis, because entire length of the conduit is used for a 3-stage esophagectomy, and there is more tension at the site of the anastomosis in cervical anastomosis compared to intrathoracic anastomosis. This is another study, Indocyanine Green utilization to prevent anastomotic leaks. They evaluated almost 1,400 patients, 41% used ICG, ICG dose ranged between 2.5 to 25 mg. Assessment ranged from 15 seconds to 90 seconds after injection. And if we see the anastomotic leak, it's 15.4% in non-ICG group versus 10% in the ICG group. There is no difference in pulmonary complications, mortality and LOS.